Hello all, and thank you very much for joining us. It's now 6:05, and I would like to set off the webinar for today. So by introduction, my name is Dr. Susane Nabulindo. I am the Secretary of the Kenya Society of Anesthesiologists. And on behalf of the Executive Committee of the Kenya Society of Anesthesiologists, I would like to thank you once again for giving us the opportunity to host you this year again for very successful webinars. Last year we had a series of very successful webinars before we closed off. So today marks the start of our webinar calendar for 2021. We are excited again to present to you quite interesting topics, partly from the feedback we received from you people as attendees from the last webinars. This year, we are going to have webinars twice a month. That will be the second Thursday and the fourth Thursday of the month. You will receive invitations on time, as has been before. So without further ado, today we are honored to have a speaker who is very well experienced in the topic of the day. So Dr. Ali Chandani has now joined us as part of the anesthesia family in Kenya, but he has practiced in the United States of America for a very long time. And he has vast experience in the subject of daycare surgery, both as providing anesthesia and also on the business front of it. So today, he will basically talk to us about setting up a daycare surgery practice from the anesthesiology perspective. So I will let Dr. Chandani introduce himself as he starts so that we know him and we shall learn from him going forward. Dr. Chandani, welcome.
Thank you very much, Dr. Nabulindo. Can you all hear me?
Yes, we can hear you very well.
Okay, thank you very much for that kind introduction. And I would like to thank the Kenya Society of Anesthesiologists for inviting me to come and speak to you today. As Dr. Nabulindo pointed out, this is my favorite topic to talk about. I've spent most of my career in the outpatient or daycare surgery setting, and I'm very happy to share my knowledge with you. So let's go ahead and get started. I did my medical school internship and residency training in the United States. At that point in time, I wanted to do a regional anesthesia fellowship, but not many were available then. So I took a job as the site director for the Regional Anesthesia Fellowship Program at the Johns Hopkins University, where I spent 3 years training fellows. I then, right around this time, was the point in the United States that outpatient surgery really started taking off. And I was recruited by a private practice group in Virginia to join them. And eventually I started 2 endoscopy outpatient centers for them, 1 2-room and 1 4-room. And then I started 2 freestanding ambulatory surgical facilities, the first a 2-room facility and then a 7-room facility. More recently, I've been in Southern Florida, where I was recruited to start up from scratch premier surgery center. Right before I left, we had grown to 6 rooms and did 5,500 annual cases. So let's talk a little bit about outpatient surgery to start with. Historically, it has evolved from simple procedures on healthy outpatients. And today they are doing major procedures on outpatients, irrespective of the patient's pre-existing medical conditions. This has been one of the biggest jumps, is that taking healthy patients only to moving towards the more sicker, complex patients. This has been facilitated from an anesthesia standpoint by short-acting anesthetic, analgesic, and muscle relaxant drugs, and the revival of regional anesthesia techniques and the introduction of ultrasound guidance. This allowed opioid-sparing techniques, allowed prolonged post-operative pain management, and allowed patients to recover at home. From a surgical standpoint, at the same time, there were developments in minimally invasive surgical techniques and advances in laparoscopy. And both of the combination of advances in anesthesia and surgery allowed this field to develop. Today, I'm going to start by talking about some definitions in languages. We'll move on to the benefits of outpatient surgery. I will spend some time talking about the models, the management, insurance, design of the facility, and regulations. This is a very large topic, and since I am speaking to the Kenya Society of Anesthesiologists, I will be concentrating more on the medical considerations and the anesthesia considerations. Please be aware this is a vast field, and each one of these could take a 45-minute seminar. So some definitions, daycare surgery, as it's called in Kenya. Unfortunately, I'm trained in the United States, so I tend to use words like outpatient surgery or ambulatory surgery. And even though I'm trying to change my language, I will constantly use these terms, but they mean the same thing. An ASC, you'll see this abbreviation used throughout my presentation, stands for an ambulatory surgery center, which is a daycare surgery center, an outpatient surgery center. One thing I noticed as I started practicing in Kenya when I came back was the similarity of the Kenyan and the US healthcare systems. Unlike most of Western Europe that has a single payer system, I found in Kenya and the United States, you have a basic cover for lower income people. In the US, it's Medicare. In Kenya, it's the NHIF. You have a variety of private insurance coverages for working individuals. You have gold plans for upper income individuals, and a relatively large proportion of uninsured people. This affects when you're thinking about starting an outpatient surgical facility, because these are the majority of your payers. And so you have to be aware that you have to balance these things and to negotiate with a variety of different insurance formats. I'll put in a pitch for the Becker's ASC review. It's a US industry publication. It's free. You sign up with your email address, and they talk about advances in this outpatient surgery field, new things that are coming up, new things that the insurance companies are looking for. So this is something, if you're interested in the outpatient surgical field, Becker's ASC review does keep you up to date on what's going on in the industry. So let's begin with why outpatient surgery. We start with, with specialization. Usually an outpatient surgical facility will specialize on only a few procedures. This specialization in specific procedures allows the maximization of efficiency and allows quality outcomes. There's accountability. It's a smaller organization, there's better oversight, and there's individual responsibility. Everybody knows what their role is, and everybody knows what they're responsible for. In today's day and age, customer service is a big issue, and especially since it's competitive, you can walk across the street and have something done over there as opposed to at my facility. And we always have to keep in mind that the surgeon and the patient are our customers, and an outpatient surgery center has to keep them happy. It is a market-driven process. You have the ability to pick and choose your cases. You can pick the most lucrative procedures. It is a for-profit environment. It is volume-driven. By that, I mean, if a case is posted on your schedule in a hospital and it doesn't get done, it doesn't get done, and you put it off until tomorrow. In an outpatient center, that's not an option. You have to do every case that's posted, and your bonuses, remunerations, and things like that are driven by the number of cases. So there is an incentive to do work there. Convenience. From a patient standpoint, there is the convenience of recovering in their own home, a familiar environment. For the physicians, they have more control over their work schedule and environment. From a stress standpoint, from a patient stress standpoint, there is less stress, and this has been demonstrated by studies, especially for the children and the elderly, when they undergo an outpatient procedure as opposed to going to the hospital to have a procedure done. In today's day of COVID, this is another issue that people do not want to be going to hospitals, and outpatient surgery facilities are filling the gap. The predictability issue, there is better control of scheduling of surgeries, and there's no unanticipated emergencies delaying the schedule. This keeps surgeons very happy. From an efficiency standpoint, Munich has done a very good study that took the same procedure done in a hospital and done in an ambulatory surgical facility. The time spent by a patient in an outpatient surgery center was about 26% lower than the time spent in a hospital for the same surgery. The last two issues are, of course, the ones that people always want to know about: cost saving and insurance. So let's address those. Cost saving. In the United States, outpatient surgical facilities reduce the cost of outpatient surgery by about $38 billion per year compared to hospital outpatient departments. More than $5 billion of that cost saving accrues directly to the patient through lower deductibles and coinsurance. In California, now Medicare being the government insurance program, ASCs save Medicare $2.3 billion a year. If you include the commercial providers, i.e. the private insurance, that number is closer to $5 billion in cost savings. And that's to the patient due to lower deductibles and lower copays. So let me give you an example. Medicare, the government insurance, will pay an ambulatory surgery center about 50 cents on the dollar compared to what they pay a hospital outpatient department for the same procedure. For example, a cataract, the hospital, the patient is still having outpatient surgery in the hospital. The hospital is paid $1,745. An outpatient surgery center will be paid $976 for the same procedure. So these are how the cost savings are accrued. How does an ambulatory surgery center make money when it's getting paid half of what a hospital does? It's because it's a specialized environment that focuses usually, in some cases, only on doing cataract surgeries. So they're able to reduce their costs that way. So, infection rate. These are for outpatient surgery. 8.95 of every 1,000 patients developed a surgical site infection, SSI, following a procedure in a hospital outpatient setting. The same number for an outpatient ambulatory surgical facility was 4.84 per 1,000. That's about half. Outpatient surgical procedures were associated with lower rates of urinary tract infection, pneumonia, venous thromboembolic events, and bleeding requiring transfusion. Outpatient status was independently associated with a reduced 30-day medical morbidity, and there was no significant difference with respect to surgical complications, unplanned reoperations, unplanned readmissions. So what I'm showing you in this slide, and it's slightly difficult to see, I apologize. The top graph starts in 2000 and ends in 2008, and it's the number of freestanding ambulatory surgery centers in the United States. As you can see, they've gone from about 3,000 in 2000 till about 6,000. We have doubled the number. The bottom graph over there shows the proportion of all surgeries done in the United States that are done inpatient versus outpatient. Starting on the left, 1980, starting to the right, 2008. The blue numbers are cases done outpatient. The red ones are cases done inpatient. As you can see, over the past 30 years, there's been about 10 to 15% of patients were done outpatient. In 2008, that number was 60%. Ambulatory surgery centers perform more than 7 million procedures annually in the Medicare database for patients needing same-day surgical, diagnostic, and preventative procedures. So I think I've so far talked to you about the benefits of outpatient surgery, and have shown you that a cost-driven medical system like the United States has also seen the benefits of outpatient surgery, and the results are showing it as an increased number of outpatient centers and an increased proportion of all surgical procedures that are done on an outpatient basis. So there are various models for outpatient surgery centers. You have a hospital integrated model, and that's ambulatory patients are managed in the same surgery facility as inpatients. So this is what you see on a pretty regular basis. These are patients who come to the come to the hospital for surgery. They are day surgery patients, but it's the same operating rooms, the same operating room teams. That's a hospital integrated. A hospital-based ASC model is a separate ambulatory surgical facility within a hospital that handles only outpatients. The freestanding model may be associated with a hospital or medical center, but they are housed in separate buildings. They share no space or patient care functions. The pre-op evaluation, surgical care, and recovery occur within this autonomous unit. And then the fourth model is an office-based model. And these are operating or diagnostic units that are managed in conjunction with physicians' offices. There are various management models that you see with outpatient surgery centers. I've put the review for a Becker's ASC article that talks about all the different models, the benefits, the risks, what you can find in all the models. I've summarized the four most prevalent, the four most in-use models. In the first case, you have a physician management company joint venture. And in this case, the management company owns a varying amount or none of the equity in the facility. The physicians own the rest of the equity. You can have a physician hospital joint venture. You can have a physician hospital management company joint venture. And then the fourth one is the independent physician-owned management model. Number four, the independent model is where outpatient surgical facilities started out with. They then realized they weren't very good at the management aspect and have then developed all these other models. Insurance companies. As if you are setting up your outpatient surgery center, this is going to be the bane of your existence because you have to negotiate with insurance companies for payment. I have posted 4 very good articles that talk about the various aspects that you have to deal with when you're entering negotiations with insurance companies. There are certain things you should do, there are certain things you shouldn't do, and there are ways to negotiate better rates. As I get later on into the presentation, I will talk about some of these things. I want to briefly mention now that you have to convince these insurance companies, especially in Kenya, where outpatient surgery is not very prevalent, that they need to think of this as a viable option for their patients. And the way you do that is from a cost perspective. You can do that from a outcome perspective, infection rates, mortality rates, and you can do that from a patient satisfaction perspective, showing them patient satisfaction surveys after their patients have used your facility. With regard to the physical facility and regulations, outpatient surgery centers can be anything from new construction to modification of an existing facility. I have an article from Becker's on designing and building your own freestanding ambulatory surgery center. That same article does talk about modification of existing facilities. What we've seen in the United States is that in smaller rural areas where land and buildings are not expensive, you see a lot of new buildings, a lot of new construction for ambulatory surgery centers. In the cities, especially in New York City, you'll have modifications of office buildings, modifications of parking garages into outpatient surgical facilities. With regard to regulations, the Kenya Medical Practitioners and Dentists Council is mandated under the law of Kenya to register and issue licenses to all private, community, and faith-based health facilities. Their website, which I've provided over there, provides the requirements that you have to go through and you will be inspected on in order to open a facility that meets the guidelines to practice in Kenya. What I do want to say in addition is there is no difference in expectation for standard of care, legal liability, or equipment requirement, whether you are having your surgery in a hospital or an ambulatory surgical facility. You still have to have the code cart, you still have to have the defibrillators, you have to have your malignant hyperthermia protocols, your difficult airway algorithms. There is no difference in how the procedure is actually performed. So on the next couple of slides, I've made a list of outpatient procedures that are being done today in the outpatient setting. From the dental, you can see the facial fractures. Gastroenterology was one of the earliest specialties to enter the outpatient field. And you often see freestanding solely gastroenterology centers that specialize in upper and lower endoscopy and ERCP. General surgery, the smaller procedures, yes, you can see those being done in an outpatient facility, but laparoscopy, including laparoscopic splenectomy and adrenalectomy, are also being done in the outpatient setting. Mastectomy and breast surgery have recently joined the outpatient surgical field and are a growing proportion of the surgeries in the United States. Gynecology, again, the smaller procedures, but I will point out the laparoscopic hysterectomies and the open hysterectomies as well. The vaginal hysterectomies are being done in the outpatient field. Ophthalmology was another field that entered the outpatient field very early. And with the exception of open globe procedures, open globe meaning traumatic open globe procedures, there is no ophthalmology procedure that cannot be done in the outpatient setting. For ENT, adenoidectomy and tonsillectomy for pediatric patients has long been a mainstay in the outpatient field. I'll point out that thyroidectomies are also being done in the outpatient surgery setting. Orthopedic was another early specialty that entered the ambulatory surgery environment. And especially with the use of nerve blocks, a lot of procedures that used to be inpatient procedures have been converted into outpatient procedures. In the United States, any upper extremity surgery, no matter what, can be done as an outpatient. Any below the knee lower extremity surgery is done as an outpatient. And total joint replacements, shoulder, knee, and hip. The emerging field in orthopedics right now is back and spine surgery. Historically, only microdiscectomy and laminectomy were done, but now limited and more extensive spine fusions are also being done in the outpatient setting. Interventional radiology, for example, pacemaker insertion or revision, fluoroscopic guided biopsy, diagnostic catheterizations are all done. Pain clinic is another place that is well suited to the outpatient field. Plastic surgery was one of the first fields to enter outpatient surgery, and all their procedures are done there. Finally, urology, including laparoscopic prostatectomy and nephrectomy, are also done in the outpatient setting. So what the procedure considerations when you're choosing what sort of procedures can be done in the outpatient? The first thing is you have to know your surgeon. And you have to know that your surgeon is capable of doing it, and they're capable of doing it in the time that they state they're capable of doing it. You want to design a physician group that can share equipment in your ambulatory surgery center. So for example, laparoscopic equipment, arthroscopic equipment, and endoscopic equipment can share the video towers. This minimizes the need to buy additional expensive equipment, and you can share. Historically, the maximum surgery duration for outpatient procedures has been 3 to 4 hours. However, that is being pushed, especially with some of the bigger spine procedures that are being done today. There cannot be any need for blood products. This is one of the biggest limitations of outpatient surgery. It makes it too expensive to have a blood bank or a blood bank facility, and so this is not possible to do in a cost-effective manner in the outpatient setting. Absolute contraindications to outpatient surgery. These are quite obvious: poorly controlled chronic illness, such as unstable angina, symptomatic asthma. Chronic centrally active drug therapies like monoamine oxidase inhibitors, active cocaine use will affect your anesthetic and your recovery from anesthesia. This is generally considered a contraindication. Premature infants less than 60 weeks post-conceptual age requiring general anesthesia. This is for the monitoring requirement. They have to be monitored for post-operative apnea. That cannot be done outpatient. If there is no responsible adult to take care of the patient at home, that's a contraindication. And of course, patient refusal. Note that a body mass index greater than 40, the presence of sleep apnea, age greater than 100 years, stable coronary artery disease, stable end-stage renal disease on hemodialysis are not contraindications for outpatient surgery, and these patients are successfully done in the outpatient setting. The primary predictors of unanticipated admission have to do with the type of the surgical procedure. The more involved or the more invasive the surgical procedure, the more likely there is to be an unanticipated admission. And then the associated complications of anesthesia and surgery, be that pain, post-operative nausea and vomiting, or blood loss. These are the major factors that affect your unanticipated admission rate, and this should be considerations when you choose what procedures to do. So moving on into the nitty-gritty of how to do it, the preoperative assessment, the sequence of events is very similar to what we're familiar with in the anesthesia world. It's nothing new. There are the three primary components of the preoperative assessment: the history, the physical exam, and the laboratory evaluation. Usually in the outpatient setting, you'll have either a computerized online questionnaire that the patient fills out, or with a less educated population, you use a telephone interview by a trained preoperative nurse. Ideally, this happens 1 to 2 weeks prior to the scheduled procedure. In addition to giving you time, this also has been shown to reduce patient anxiety, that they are at least aware of what's going to happen to them. This information is then reviewed by the anesthesiologist, and this guides the subsequent management, whether they need medical, cardiac clearance, any laboratory testing. I want to point out that there's been a very good study done by Okocha et al. That shows that routine testing of all patients does not lower the risk of complications, nor does it improve the outcomes. In fact, in many of the surgery centers, they will have specific laboratory investigations for specific patients with medical diseases for specific procedures. For example, somebody coming in for a colonoscopy does not get any routine preoperative testing. Somebody coming in for a knee replacement will get their hemoglobin checked. And if they have hypertension, you will also check their electrolytes, things like that. All paperwork, the consent form, the history, the consultation notes, the laboratory testing should be reviewed before the patient even arrives at the center. Originally, outpatient surgery was limited to patients with ASA1 and ASA2 classification. This has changed, as I mentioned earlier. Patients with pre-existing medical conditions have been shown not to have an increased incidence of perioperative complications or unplanned admissions, as long as their pre-existing medical conditions are stable for at least 3 months prior to the scheduled procedure. In certain cases, for example, if you suspect a difficult airway, you might invite the patient in for an in-person preoperative visit, but this is usually a rare event. This is an example of the sheet that a preoperative nurse who's making the phone call to a patient will fill out. There are check boxes of things you want to ask about within the cardiovascular system: blood pressure, coronary disease, angina, from pulmonary standpoint, asthma, COPD, etc. All the organ systems are covered. There's a space for their prior surgical history. There's a space for their allergies, for their medications. So this can be filled out by a non-anesthetist and then given to the anesthesiologist to review. The goals of the key elements of the preoperative period are just like for a regular procedure, you stabilize the coexisting disease, the blood pressure, the diabetes. You encourage the prehabilitation exercise, and you encourage smoking cessation. You optimize their patient comfort by minimizing anxiety and discomfort. You ensure adequate rehydration by replacing fluids. You use appropriate prophylactic therapies to prevent post-operative complications, be they pain, ileus, nausea, and vomiting. If you appropriately prepare your patient for surgery prior to the day, you can prevent unnecessary delays, no-shows, last-minute cancellations, and substandard perioperative care. So the preoperative preparation also involves things other than medical. It involves the economic, payment, insurance, invoicing. This all has to be arranged. The patient is only coming to your center once. You will not be seeing them again. You have to provide written and verbal instructions regarding arrival time, place, location. You want to provide written and verbal fasting instructions. With regard to pre-existing medications, the trend is to continue all chronic medications up to the time of surgery, with the possible exception of blood thinners. Oral medications can be taken with a sip of water morning of surgery. Information regarding the post-operative course including medications and side effects and effects of cognitive skills in driving, should be given in the preoperative period so the patient can know what to expect and can plan for this. They also need to be made aware that there's the need for a responsible adult to care for the patient for at least the first 24 hours post-discharge, and if they're having a significant procedure, for even longer. Pre-operative anxiolysis. High levels of pre-op stress are associated with slower recovery, greater post-op analgesic requirements, and greater antiemetic requirements. There are non-pharmacological interventions, the anesthetist pre-operative visit, pre-op educational programs, the timing of the pre-operative interview, as I said earlier, instructional videos, play-oriented books, pamphlets, and videos for children. The pharmacological interventions are also there, and we're all aware of them. Prospective studies have not found prolonged recovery after the appropriate dose of sedative pre-medication in the outpatient setting. And I've given some examples of what is used typically in the outpatient setting for anxiety. Analgesia. The motto for analgesia in the outpatient setting is preemptive multimodal analgesia. Preemptive, you want to prevent the patient from getting to a state where you have to give large doses to rescue them from pain. Multimodal, you want to use medications with different mechanisms of action that all act synergistically to produce a better overall effect. The medications typically involve an oral opioid analgesic. Many non-opioid analgesics, such as non-steroidal anti-inflammatories, paracetamol, the steroids, and the neuromodulators, such as pregabalin or gabapentin. Local anesthetics play a large role in the perioperative analgesia, be they by infiltration or peripheral nerve blocks. Various studies have found that a fixed dosing schedule beginning in the preoperative period, i.e. right before surgery, and extending into the post-discharge setting has been the patients who start and take a fixed dose regimen often use fewer pain pills than ones who only take on an as-needed basis. The pain regimen, of course, should take into account the surgical procedure, the anesthetic technique, the medical conditions, and social factors. Post-operative nausea and vomiting. The reason I spend a good amount of time here is this actually, in my experience, has been the #1 reason for delayed discharge, unanticipated hospital admission. There are patient-related factors, age, gender, female gender are more likely, coexisting disease, diabetes for the gastroparesis, history of motion sickness or nausea and vomiting. The one known medical benefit of smoking cigarettes is people are less likely to throw up after anesthesia. Their level of anxiety and concurrent illness. There are anesthesia-related factors related to pre-medications, opioid use, the type of anesthetic agents you use, the type of anesthetic agents used for induction, maintenance, and reversal. In reversal, I'm talking in particular about neostigmine, which has been known to greatly affect the risk of postoperative nausea and vomiting. There are, of course, surgical-related factors that contribute to postoperative nausea, vomiting, the type of procedure, the length, whether there's blood in the gastrointestinal tract, etc. So this, like I said, PONV prophylaxis is the single most important factor implicated in delayed discharge, unplanned admission, and patient dissatisfaction. When they've surveyed patients and asked them, what is your biggest concern about having surgery? A good portion of the patients will not say pain. They will say nausea and vomiting afterwards. And if you ask them which they would prefer to have, whether they prefer to have pain or would they prefer to have, or would they prefer to avoid postoperative nausea and vomiting, the majority will say, I will take pain if it means I do not throw up. So that's something to keep in mind. There are a number of pharmacological interventions. The butyrophenones are well known to work, the phenothiazines, the serotonin antagonists that are probably the most widely used, the neurokinin antagonists. Steroids have a role to play. Benzodiazepines do have a role and they do decrease nausea and vomiting. I will mention the anticholinergics, in particular the scopolamine patch that has been shown to be very helpful in patients with a history of motion sickness against nausea and vomiting. There are other non-pharmacological methods, acupuncture and TENS at the P6 acupoint. There is a commercial product known as the relief band. It's a band people wear on the wrist that puts pressure on this P6 acupoint. And that, by scientific studies, has been shown to work. So let's move on to the intraoperative period. So the key elements in an intraoperative period is you utilize an anesthetic technique that optimizes surgical conditions while ensuring a rapid recovery with minimal side effects. We all wish we could do that every time. You administer local anesthetics via peripheral nerve blocks, wound infiltration and or installation, apply multimodal analgesia and antiemetic prophylaxis, minimize the use of surgical drains and excessive amounts of fluid. The basic anesthesia techniques are the ones we all know about. There's nothing new. There's no special techniques you use in the outpatient setting. The only things are you'll tweak the types of medications you'll use, and you'll tweak the type of technique you use for a procedure. But the techniques remain the same. I'm just going to make some general comments about the techniques because I'm going to assume you are aware about these techniques. From a general anesthesia, in the US, an LMA is preferred over an endotracheal tube. This avoids the need for muscle relaxation and reversal, which is associated with postoperative nausea, vomiting. Propofol as an induction agent is preferred versus a barbiturate, again for the nausea and vomiting, or ketamine. The shorter acting inhaled agents like sevoflurane are preferred for their quicker emergence. And there is a tendency to avoid nitrous oxide because of its association with nausea and vomiting. Regional anesthesia, I will come back and talk about this a bit later. I just want to mention that you can do mini dose spinals, larger dose short acting spinals. If you're worried about spinal anesthesia, epidural anesthesia with 3% 2-chloroprocaine is uniquely titratable. And if you're worried about your spinal not lasting long enough, you should consider CSE. These are all acceptable techniques. In the intravenous regional anesthesia, by this I refer to the beer block. And it's an excellent procedure for short superficial surgical procedures of the upper extremity. Lidocaine with any number of adjuvants can be used for procedures like carpal tunnel, ganglion cyst, even fractures of the fingers. Peripheral nerve blocks have really allowed outpatient surgery to flourish by bringing in a lot of orthopedic techniques and orthopedic procedures to the outpatient setting. But nowadays, they've also brought the whole general surgery fields associated with mastectomy. The new erector spinae and serratus plane nerve blocks have really done wonders in allowing these procedures to be converted into outpatient procedures. At the minimum, I say you should be familiar with an interscalene, some sort of upper extremity, be it supra or infraclavicular. The femoral or adductor canal block is a mainstay of joint replacements, knee replacement surgery, and the popliteal being used for anything below the knee. Also, the tap block has its role, the rectus sheath, and like I said, the erector spinae and the serratus plane. A lot of times continuous catheter techniques are used because these allow you to prolong the anesthesia and they have opioid sparing effect. So it has a big role in they're more ready to leave at the end of the procedure, they recover faster, and there's less nausea and vomiting. Nerve blocks can be used as a sole anesthetic or in conjunction with another technique. Monitored anesthesia care is one of the mainstays of outpatient surgery. This is different from IV general anesthesia. It's mostly for gastroenterology and ophthalmology or in conjunction with another technique. And then a quick note on local infiltration. There's good evidence that pre-incisional injection of local is superior to injection at the time of closing. Cantori have done a very good study with regard to laparoscopy and injecting your laparoscopic port sites before you create them, and how that decreases pain and analgesic consumption for days post-operatively. And then Bagul has done the study on thyroids, and where pre-incisional infiltration of local anesthesia has no effects on bruising, wound cosmesis, which is what the surgeons complain about, and reduces post-operative pain management. So outpatient general versus spinal anesthesia. So there's been a long controversy in whether spinal anesthesia should be performed on outpatients. And the definitive study came out last year. It was done by Capdevila. He's a regional guy at the Hospital for Special Surgery in New York. He studied 33 private or public hospitals performing ambulatory surgery. And the two issues with regard to spinal are that how long it takes to urinate and how long it takes to ambulate. Unsurprisingly, both were shorter in the general anesthesia arm compared with the spinal anesthesia arm. However, the median time to hospital discharge was equivalent in both study arms. And note that this is a hospitals performing outpatient surgery. So these weren't patients who were being admitted. So hospital discharge means recovery room discharge. Spinal anesthesia, when they polled the staff, the nursing staff, spinal anesthesia with short-acting local anesthetic was preferred to general anesthesia by the recovery room staff and was associated with a high degree of patient satisfaction. So this should not, so for those of you who worry about doing spinal anesthesia in the outpatient setting, you have one good study to back you up. The key elements of the post-operative period in the outpatient setting are, number one, allow patients who meet discharge criteria to be fast-tracked. We'll talk about fast-tracking. You ensure adequate pain control, and you encourage early ambulation and resumption of normal activities of daily living. This is very similar to what we already know and do. So the discharge or the post-recovery period is divided into 3 stages. The early recovery, the time interval where the patient emerges from anesthesia, recovers control of their protective reflexes, resumes early motor activity. The Alderetti score that we're all aware of in the recovery room monitors this early recovery period. The intermediate recovery period is when a patient begins to ambulate, drink fluids, void, and prepare for discharge. The late recovery starts when the patient is discharged home, and it continues till complete functional recovery and the patient resumes their activities of daily living. That's ADL. Sorry for the abbreviation. Fast tracking can be one of 2 things. Historically, it's bypassing the post-anesthesia care unit completely. In a more practical terms, it can be accomplished directly in the recovery room. It's called PACU fast tracking by creating a specialized area within an existing PACU, such as a step-down unit. You have beds for patients recovering from general anesthesia, chairs for patients recovering from regional anesthesia or monitored anesthesia care. This is the PACU fast track criteria. They look at these 7 criteria, and these 7 criteria are assessed on the patient at the conclusion of the surgical procedure while the patient is still on the operating room table and the dressing is being put on. You assess their level of consciousness, their physical activity, hemodynamic stability, respiratory oxygen saturation, postoperative pain, and nausea, vomiting. If a patient gets a score of greater than 12 with no individual score below 1, they are a candidate to be fast-tracked through the PACU. Post-anesthesia discharge scoring system. This is how you assess a patient when they're ready to leave the facility. Because unlike a hospital where they're going to a hospital room or somewhere they're going to be monitored, here they're going out to be taken care of by lay people. Chung, Chan et al. Have done a very good study in the Journal of Clinical Anesthesia on outpatient discharge criteria and what the predictors of a successful outpatient discharge should look like. They monitor the vital signs, the activity and mental status, pain, nausea and or vomiting, surgical bleeding, and intake or output. A score greater than 9 is considered fit for discharge from the facility. Follow-up. Follow-up is the same as with any procedure that we do. In this case, it's done remotely, usually via telephone because the patient isn't in the hospital anymore. Usually it's a questionnaire based to avoid missing relevant information and for documentation purposes. So you will have a questionnaire with all these questions on it and you'll make a phone call to the patient and you'll check box or write in their answers. To come back to what I was talking about with insurance earlier, collecting patient satisfaction scores, surgical and anesthetic outcomes, and complications at your facility are key when you're negotiating reimbursement with insurance companies. They will ask for this information. So you have to have this information available when you are negotiating with them, and this is a good time to collect it. So I thought now would be a good time to look at an example of how what I've talked about actually transfers into actual practice. So we're going to take an endoscopic sinus surgery patient who's having an outpatient procedure done. Pre-op, which I mean 1 to 2 weeks prior to the scheduled procedure, the surgical scheduling will happen. The facility will look at equipment availability. At the time of surgical scheduling, you ask that the surgical informed consent is provided to the facility. You will look into insurance and payment issues. The anesthetic preoperative phone call will then, an evaluation process will take place in these 2 weeks. Instructions are given, NPO guidelines, fasting guidelines, location, arrival time, medication instructions, post-operative expectations, the name of the responsible caregiver. Now we come to the morning of the surgery where the patient arrives at your facility. If it takes about 30 to 45 minutes to go through the registration process, keep in mind that you have to have a secure process for storage of their clothing and belongings that they will be wearing again when they leave. You'll take them into the preoperative holding area, and for about 30 to 60 minutes, they'll be evaluated by the nurse, language issues, social issues, review their medications, confirm they have a caregiver, transportation information, and general information is given. Then the anesthetic in-person evaluation takes place. The anesthesiologist has already reviewed the chart from the preoperative. So it's more of a review of the information, discuss the plan, obtain informed consent, and answer any questions. Vital signs are obtained, an IV is placed. Preoperative medications are given. In the case of sinus surgery, it'll be an anxiolytic like midazolam, 1 to 3 milligrams. Your antiemetic, since sinus surgery is an emesis-inducing procedure, we will typically start with a steroid. And if the patient has a history of motion sickness, you'll use some sort of scopolamine patch or phenothiazine like Phenergan. Antibiotic is administered. Because they're having sinus surgery, the intranasal vasoconstrictors are administered. And the first analgesic, paracetamol, is given orally. The surgeon will evaluate the patient in the preoperative holding area and mark the site. Operating theater, typically about 2 hours. General anesthesia is given via laryngeal mask airway with spontaneous ventilation. Propofol, sevoflurane, fentanyl. A non-steroidal drug is administered after the surgeon confirms adequate hemostasis is obtained, and the rest of the antiemetic, usually the ondansetron or the serotonin antagonist is given towards the end of the case. Note that there will be pre-incision infiltration of local anesthetic with a vasoconstrictor like epinephrine or cocaine by the surgeon. Then the recovery room for this endoscopic sinus surgery is typically 45 to 90 minutes. In addition to normal recovery, one assesses hemostasis. You assess nausea prior to any oral intake. You assess pain, institute post-op analgesia. And for example, if the patient is taking tramadol at home, or is prescribed to take tramadol at home, you start giving them tramadol. If they're prescribed to take oxycodone, you give them oxycodone, etc. And you ambulate them out of bed. You assess fluid status because orthostatic hypotension when they stand up can trigger nausea and vomiting. Discharge process will typically take 15 to 30 minutes. You discuss post-surgery discharge instructions, wound care, dressing changes, activity restrictions, and ensure the patient has adequate supplies for these things. You discuss the anesthetic follow-up. You tell them they'll receive a phone call tomorrow, and you confirm their contact information. You also provide the emergency information. This is who you contact if something goes wrong. This is when you should think about going to a hospital. This is when you contact the center. This is when you contact the surgeon, and you make sure they have all of that information. And because you're bombarding the patient with so much information, written information is best. Usually, since an ambulatory surgery center specializes in certain procedures, you will have a discharge packet already pre-printed, and you go through the patient with that. So that brings us to the end of my presentation. My email address is there for those of you who need to ask any questions. And thank you very much for listening.
Yeah, thank you very much, Dr. Chandani. That was quite a comprehensive and well detailed presentation. Yes. Thank you very much again for the participants. I can see we are almost about 200 now. And for those who joined us at some point, our topic today was setting up a daycare surgery practice, which was presented by Dr. Ali Chandani, who has had extensive experience in daycare surgery in the United States of America. And now he has joined us as part of the anesthesia team in Kenya. So without wasting more time, we'll now get into the question and answer session. And I will try to go through the chart and pick up the questions. So Dr. Ali Chandani,
Yes.
you will just unmute yourself and answer as I ask. So the first question, okay. So the first question was from Dr. Guaro. She is asking about sevoflurane. I think you mentioned in one of your slides that one of the ways of tweaking anesthesia is choosing to use drugs like sevoflurane, where reversal is quite fast. So her question is, did you ever experience or encounter delirium from using sevoflurane?
Yes, unfortunately, the answer to that question is yes. Especially in the pediatric population, I've seen this as a problem. I've never encountered it in an adult. What we have found works in this population is if these patients get a preoperative anxiolytic like midazolam. So we've in pediatric patients where we're going to use sevoflurane, we almost always give midazolam to decrease the risk of emergence delirium. Once emergence delirium happens, that is a concern, and you just have to watch the patient. Luckily, it is self-limited in most cases, and it does eventually pass.
Okay, thank you very much for that answer. Another question was coming from Adekumbi, who is asking, how long does a patient have to stop smoking before daycare surgery? Okay. I think the preoperative preparation of the patient, if you find a patient who is smoking, how long do you ideally want them to stop smoking before they come into surgery?
Okay, thank you very much for the question. This is a bit of a controversial issue because as doctors, we're supposed to tell patients to stop smoking. So that's part of why we tell them that. However, if you look at the airway reactivity studies that have been done with regard to smoking, you find that after somebody immediately stops smoking, for anywhere from 2 to 4 weeks, they have airway hyperreactivity. And you have an increased incidence of laryngospasm on emergence from anesthesia for those 2 to 4 weeks. So while you want them to stop smoking because it's good for their health, if they stop smoking and you have them in those 2 to 4 weeks, you do often have an increased risk of airway complications. So you have to be aware of that. What we typically do with patients who have who are smokers or who have recently quit smoking, we pre-medicate them with glycopyrrolate, a 0.2 milligram dose to dry up the secretions. That does help to some degree. And prior to extubation, we use intravenous lidocaine at a dose of about 1.5 milligrams per kilogram. And that has been, and that I think has been shown to decrease the risk of hyperactivity when you're extubating a patient. So ideally, more than 2 weeks prior to the procedure. Ideally, more than 8 weeks, but ideally more than 2 weeks because those first 2 weeks is when the patient's airway is more hyperreactive. I hope I got your, I hope I answered your question.
Yes, thank you. Ashok Shah says, makes a comment to say that topical intraocular lignocaine is being routinely used for cataract surgery, or that is topical or intraocular lidocaine, is routinely being used with very minimal side effects or none at all in outpatient surgery.
He's exactly right. If you look at the proportion of ophthalmologists doing their procedures today, you can tell the age of the ophthalmologist by the type of anesthetic that they ask for. So the very old ones who've trained a long time ago will ask you to place a retrobulbar nerve block for them. The ones who are in the middle age, who trained in the past maybe 10, 15 years, 15 years ago, will do the retrobulbar nerve block themselves. And then the newer ones will do it exclusively with topical anesthesia. And so in the United States, what this translates to is they will ask you just to sedate their patient. For example, the population having cataract surgery are often elderly, and for them to lie still on the hard stretcher is difficult. Sometimes they have restless legs. So your anesthetic is more about keeping the patient comfortable lying on the bed as opposed to anesthetizing the eye.
Okay. Good. So another question from Dr. Patrick Olang. Dr. Olang wants to know, do you assign a nurse to be contacted in case of any post-discharge concerns such as pain or hemorrhage?
Okay, so what we do have, that's an excellent question. Thank you very much. Because the post-operative care of the patients who are having outpatient surgery is a big concern to an anesthesiologist. It's not something we're used to, sending patients home where they're not being monitored. And so with regard to, we split our post-operative instructions. So for example, surgical related issues like hemorrhage, we will have the surgeon's on-call number available to them overnight. With regard to pain, nausea, vomiting, and general questions, usually somebody from the center will be assigned to triage calls for the night. Oftentimes, the patient will just call that one triage number, and then the person who's assigned that night triage will direct it to the appropriate person. But yes, we do have somebody assigned 24/7, especially if you have peripheral nerve block catheters out. You will have somebody on call 24/7 to answer questions.
Okay, thank you for that. And we have another question from another participant. Ajayoba wants to know, does the distance of the facility from where the patient lives affect patient selection for daycare surgery?
Typically, it does not. I've practiced, especially when I began my practice as a resident in New Mexico. New Mexico is a very rural state, and we used to get patients who used to drive 2.5 to 3.5 hours to come into the center to have their surgery done. What we are most concerned about is that they have a facility near where they're located, where an emergency such as hemorrhage can be quickly addressed. So as long as they have something near them that can take care of an emergency, we are satisfied with it. And it doesn't affect. If they have nowhere near where they're located that can take care of an emergency, then a hybrid model is where the patients will oftentimes come for outpatient surgery and stay in a hotel near the facility for overnight, for the night, or for an extra night. So that there are ways of overcoming it, but really what you want them to have is some place that can deal with an emergency in close proximity to them.
Okay, thank you. There's one person raising their hand, that is Best Imadie. Maybe the Shelmith, you can unmute Best so that they are able to ask the question. She has the hand raised. Meanwhile, as the host unmutes her, I can ask another question where one participant is asking, you talked about giving pre-op paracetamol as the patient waits for surgery. At exactly what time do you give the paracetamol? That is the question.
Our cutoff that we used was 30 minutes. So we tried to give it not more than 30 minutes, but up to 30 minutes, we've safely given paracetamol with a small sip of water, and that does not appear to be a problem. Thank you very much for the question.
Okay. Lingugi asks you to comment on carbohydrate drink during in the fasting guidelines and the outcomes.
Hello?
I think, hello?
Yes.
Yeah. Hello. Good evening, Sama. Good evening, everybody.
Good evening, Ben. Go ahead.
Okay. Okay. My question is the oral paracetamol I should be giving pre-op. I wanted to ask at what time should you be giving pre-op? Because I know it's going to be swallowed with water and all that. That might increase the gastric content and all that. Since we are doing most likely, for example, with GA, we're going to use an LMA. So, and with that, how do we regulate and make sure probably the quantity of water, when to take the drug, the oral paracetamol, and all that, you know?
Okay. Thank you very much for your question, Best. So what we have typically used as a standard for pills preoperatively is we try to administer more than 30 minutes before we administer the anesthetic. So about 30 minutes is our cutoff time. We give a limited amount of water. So we give them just as much water as it takes to get the pill down. And if we are at all concerned that the patient cannot get that pill down without a huge glass of water, we use the suppository and we use per rectum paracetamol.
Okay, while you're at it, there's another question. I think somebody wondering why give oral paracetamol and not IV paracetamol. Why do you people choose? I mean, did you choose oral
So
and paracetamol?
So the first answer to that has to do with cost. The cost of giving oral paracetamol is a fraction of the cost of what intravenous paracetamol costs. So the first thing is you are running a for-profit center, so you want to minimize your costs of medications. The second reason I give is that to my satisfaction, I have not seen independent studies, meaning studies that are not sponsored by the manufacturers of intravenous paracetamol, that show any benefits of intravenous paracetamol over oral paracetamol. The studies that they have that they have provided to me and that I have looked at have shown that paracetamol, they talk about a better pharmacokinetic and a better pharmacodynamic profile. But if you look at the outcome studies on those patients, although the blood levels get to therapeutic faster, the overall consumption of analgesia or the way the patients rate their analgesia is equivalent between the two groups. So not having seen a benefit, a major benefit for intravenous paracetamol, and given that we have a medication that works well, oral paracetamol works very well if you give it 30 minutes before surgery. They have a 2-hour procedure. It is peaked and working well when you're in the recovery room. So those are the reasons why we do oral versus intravenous. I saw a question from Mr. Kenemo about what considerations to minimize discharge from patients operated under spinal anesthesia.
Yes,
So
go ahead and answer that.
Can I go with that question?
Yes, go ahead.
Okay, so the considerations we use, we have tried a number of different techniques. The first one is you know your surgeon. And if the surgeon tells you that the procedure is going to be this long, then you trust your surgeon, having worked with them and trusting them, and you give them a spinal that you know will last the appropriate amount of time. For example, let me use. So we have our surgeon who does total joint replacements, total knee replacements. His skin-to-skin time on a total knee replacement is anywhere from 55 minutes to an hour and 10 minutes. So we know that it's not going to last more than an hour and 20 minutes. So we are comfortable giving lidocaine or prilocaine spinals that 50 to 60 milligrams will last you 1 hour and 30 minutes. So you try and match your spinal to give you a little leeway on the operative time. And so that if, for example, it takes him a little longer to close or a little longer, you do have the extra 20 minutes. And then you're using that, within 3 hours, that spinal is long gone. So if you place it at 7 o'clock in the morning, surgery starts at 7:30. They hit recovery room at about 9:15. By 10:30, that spinal is gone and the patient is good to go from the purely spinal point of view. So you try and match the duration of the spinal you use with what the surgeon has posted. The other thing is when our spinals have not lasted long enough because we're trying to go on the low side, we have had to complete a couple of cases under laryngeal mask airway. But this is the hardest thing with doing spinal anesthesia in outpatients, is to time it. And so that's why other facilities I've worked at, where I didn't write the protocols, the protocol was to do a combined spinal epidural, so that you could give a lower dose of spinal medication, but if the procedure looked like it was running, you would add epidural medications to make it to the end of the case. So those are the two things you can do to minimize time to discharge.
Okay, so thank you very much. Two more questions. One question from Dr. Ngugi asking comment on carbohydrate drink in fasting and the outcomes. I think there's been push that when you are giving patients clear fluids 2 hours or 1 hour before surgery, they should be a carbohydrate-rich drink. What is your comment on that?
Dr. Ngugi, I've read the same studies that you have, and I'm in favor of these things. Especially in the outpatient setting where you want the patient to be back to their normal self as quickly as possible. Something like a carbohydrate drink that maintains homeostasis, that maintains a normal metabolism for the patient is beneficial. So I am in favor of carbohydrate drinks. And oftentimes we used to tell our patients for clear liquids includes, we used to use sodas because those are less complex carbohydrates and less healthy carbohydrates, but they tend to have the same effect. Patients do not drop their blood sugar as much. And so you get a more stable post-operative course.
So another question is from Dr. Boyle. He says, comment on patients on psychotropic drugs and patients, addicts or patients with substance use disorders coming for daycare surgery. Any specific considerations for these particular patients?
Yes. So these are often difficult patients to anesthetize simply because they're psychotropic medications. In that case, you don't exactly know how they are going to respond to your anesthetic medications. And addicts, because of their extremely high requirements or requests for opioid pain medications. So these are definitely the more difficult patients you will encounter in the outpatient setting. What we found is regional or peripheral nerve block techniques are particularly useful in these people, because one, you're interfering less with their psychotropic medications. With regard to the addicts, with regard to the psychotropic medications, with regard to the addicts, you are providing an excellent level of pain control that is independent of the opioids. And that they often appreciate that, because anybody who's tried to give anesthesia to an opioid addict will realize very quickly that you can give all the opioids in the world and they will still have pain. You give large doses and you worry about side effects. So the first thing is you try and maximize your use of regional anesthesia techniques. With regard to addicts in particular, if they're coming for if they're a chronic pain medication addict, you have them continue their chronic pain medications. For example, in the US, the way that a lot of chronic pain patients, they're maintained on the long-acting form of morphine or Dilaudid, the extended release version of it. and you have them continue those medications. Do not let them stop those medications, otherwise your life will be miserable. I can guarantee it. So you have the addicts. And then the third thing is in the outpatient setting, you are very lucky because to some degree you can pick and choose your patients. And so with regard to patients who are acutely abusing drugs, so addicts meaning not people who are on scheduled pain medications and addicted to pain medications, but people who are abusing medications or abusing drugs, those you can refuse to do in the outpatient setting. It's much easier to say no to those cases than it is in the inpatient setting. And you make the argument to the surgeon, because this is who you're refusing, they posted the case. You can make the argument of with regard to the use of resources, that your patient is having this procedure, but they are going to sit in my recovery room for 6 hours. And that means 6 hours of nursing time and 6 hours of associated cost associated. So that's the third thing I can tell you with that. If you have to do a case on a patient who's addicted, I think you would be best served by using the techniques you already know and trying to improve, trying to use as many regional techniques if you can.
Okay, thank you very much. So probably one last question before we have a comment from Dr. Olang. Kenomo is the same person who asked the question about spinal. Now he's saying, any comments on post-dural puncture headaches?
Okay.
In this setup, yeah.
So luckily, with spinal anesthetics, with the use of the smaller gauge, meaning 25 gauge needles, actually in some places in the US, they're trying to mandate the use of 27 gauge needles, which are even harder to use than 25 gauge needles. But so with the use of, I've always in my outpatient, always in my career, I've used the 25 gauge, and I use a pencil point needle, not a cutting point needle. So if you use a 25 gauge non-cutting needle, and you minimize the number of passes, I have not had a single one of my patients, my outpatients, have a post-dural puncture headache. Actually, even in my inpatients, because I did in my inpatient time, I did a lot of joints, and those were also done under spinal. And there was, I've never had a patient who had a spinal anesthetic with a 25 gauge non-cutting needle develop a post-dural puncture headache. Now, that risk does increase if you're using the CSE technique or combined spinal epidural, because that epidural needle is a lot bigger. And so if you do tend to get a post-dural inadvertent dural puncture with that large bore epidural needle, you can almost guarantee yourself a post-dural puncture headache. What we've found with those cases, and that this is an off-label use in the United States, is they do a prophylactic blood patch through the epidural catheter prior to pulling it. And I assume you know what an epidural blood patch is. So what they've done in those outpatient centers is they do a prophylactic epidural blood patch and then follow up the patient very closely. In the inpatient setting, prophylactic epidural blood patch just for a dural puncture is not recommended. And I believe the teaching and all the literature says it is not recommended. I'm telling you what people do off-label when they have an outpatient who gets a dural puncture with a 17 gauge needle.
Okay, so thank you very much, Dr. Chandani. That was a very well-handled Q&A session. So to just add some comments from our local perspective, and there was a comment from one of the anesthesiologists here that we are having a large number of daycare surgeries going on. So I'll ask Dr. Olang. Dr. Patrick Olang is one of our senior anesthesiologists with extensive practice in both public and private sector. Maybe Dr. Olang, you can make a comment on what our experience is and where we are heading or where we are with daycare surgery in this country. Dr. Olang?
Okay, yeah, I think this is a very interesting topic, and it's a good thing that it is beginning to peak. But for a long time, this is not something that has been advocated for in our practice. It's beginning to peak. Unfortunately, the pre-op preparations seem to be still a major problem. And most of our institutions, even both private and public, don't seem to have established pre-anesthetic clinics. And therefore, most of the choices are surgeon-driven. Of course, we don't do big cases like arthroplasties and so on, because those ones are definitely inpatient-driven. Again, many of our patients come from very far, and some of them are coming from areas where access to nearest medical facilities is minimized. It looks like we are going to pick up, but it's going to take a bit of time because nurses are usually also participants in the care of the outpatient the outpatient clinics, and even doing a spinal for an outpatient tends to be frowned upon because they always feel the patient will delay in mobilization, and that therefore means that they cannot go home in good time if the patient, for example, has the procedure done in the afternoon and it is done under a spinal or epidural. The patient might not be able to walk home, and then it becomes another issue. The other issue we have is that in this country, really, the most common and available local anesthetic for regional blocks, particularly spinal and epidural, is only bupivacaine, which is long-acting. And many times, depending on how one doses them, you might end up with a patient remaining numb for many hours. And that probably is one of the reasons why it is not a very common practice to do regional blocks for patients who are on outpatient basis. Now, the main reason why outpatient day surgery is not very popular in many cases is pain management. Post-op pain management many times doesn't seem to be done very well, and most patients would feel that they are better off remaining in the hospital for possibility of getting opioid injections in case the pain becomes a lot in the course of the day. So most patients really most times the patients and even the surgeons do not really advocate for outpatient surgery. Then the other problem we have is the post-discharge support. The post-discharge support doesn't seem to be very well organized, and most times, even we anesthesiologists, once we have done the cases, we are gone and we are gone, even in the private hospitals. And usually there is no contact given to the patient to get in touch with us. The only contact they have is the contacts of the surgeon, and many times they might not even be able to get the surgeon, which again is a problem. Now, the last point that seems to be still a problem, although we are beginning to get over with it, is that most patients with medical insurance tend to only have inpatient cover. And because they have inpatient cover, they do not, they come in as admitted patients to be able to use the cover. Even if they are coming as daycare surgery, they want to come in as admitted and then discharged so that they are able to use their inpatient cover. So that seems to be one of the major factors that is distracting them. The only area where I find a lot of outpatient surgeries working well is in endoscopy. In endoscopy, they do quite a bit of daycare surgeries, and they use basically the benzodiazepines, mainly midazolam. Then they use opioids like mainly fentanyl and occasionally pethidine, and then propofol where there is an anesthetist. Of course, when there is no anesthetist, They just stick to an opioid and the benzodiazepine, and which is, in this case, most of the time it is midazolam, and they seem to get away with it, although the patients, quite a number of patients who come back for repeat endoscopy experience when they had no anesthetist was very uncomfortable, so they would now require an anesthetist. The problem with the anesthetist is that once you bring in an anesthetist, there's an additional cost to the care of that patient because the anesthetist will charge. And then, of course, the anesthetist uses slightly more expensive drugs, which includes propofol, for example, and that drives the charge up. So it is mainly the patients who have had previous experience that would really like to have an anesthetist and not to be done by the endoscopy team, which is the gastroenterologist plus the assistant who is a nurse and a technician. So that's what I can say. But I think we are moving towards more and more daycare surgeries, but the infrastructure for it is not yet in place. So it's unlikely that we shall do the big cases, the type that you have, that have been described in this webinar. I don't think we shall do that. At least I don't see that being done in the next 5 years. So that's what I can say.
So thank you very much, Dr. Olan. That was from a Kenyan perspective. Again, seeing that we are away, a long way to go, but again, it's always progress going forward. And from this webinar, we can learn that we as anesthesia providers can be in the forefront in setting up and even trying to put protocols for running daycare surgery units, either within our hospital or standalone, because I know surgeons starting standalone daycare surgeries most of the time will approach anesthesia providers to look at the anesthesia side of the story. Yes, and again, an opportunity to look at as a way of starting a practice with what Dr. Chandani has presented. Dr. Gaderu has shared an experience of having a patient who had to be catheterized after daycare surgery under Spinal, and they couldn't get any of the team members who had been in their surgical team, so he had to go and do it. So those are some of the challenges that happen when you don't have good follow-up. So at this juncture, I have seen there are no more questions on the chat. I would like to recognize the presence of our colleagues from Nigeria. Professor Elizabeth Nasol, thank you very much for the members of the Nigerian Society of Anesthesiologists, quite a number in attendance. We are privileged to host you, and we hope that you will join our webinars more going forward, and we would also appreciate to join, we'll also be willing to join you in any of your activities, especially in this virtual space. Thank you very much. I also recognize colleagues from Ethiopia and Burundi. We are honored to host you, and you are welcome, and we would also like to partner you. If you have any events, then reach through our office and our members will get the invite. So lastly, some announcements for the members of the Kenya Society of Anesthesiologists. Again, I repeat, the webinars this year are going to be twice in a month, the second and the fourth Thursdays of the month. You will receive the invitation at least 1 week before the webinar, and we encourage you to attend. They are all CPD point accredited, and you'll get your CPD points or whatever way you usually get your CPD points through the office. So the recording of this particular webinar again has been done, and you can find it on the Kenya Society of Anesthesiologists website and also on our YouTube channel. And at that point, I encourage you to visit and interact with us on our social media platforms, Facebook, Twitter, and YouTube. We are planning to make this more active going forward. So please, we need your help. Go and visit the social media platforms, make comments there, discuss, so that we are visible through these very important channels. So just again, a reminder for payment of your annual subscriptions. It's the start of the year. You can reach Shelmith for details of payment. That needs to continue as even we continue organizing our annual conference. So we shall give you information about what we shall do with the annual conference this year. Last year, again, all of you understand we could not be able to have a conference, but we were able to discuss all the topics that we had planned during the webinars. So information will come to you as early as possible on how this year's conference will be conducted. So thank you very much, and expect your CPD points through your emails. And if you have any questions for us, then our email address, you can get it from our website and communicate to the office. Thank you very much. We can end the meeting there.